red pair and a purple pair. And every place in this matrix where there's a 1, there's a match. So the green pair, the green donor matches the recipient, the blue recipient. Now, every place there's a 1, you need a point score. How good of a match is it if the green donor gives to the blue recipient? So they all get a point score, and you see these point scores vary. So it turns out that the green pair could either swap with the blue pair or the red pair. If they swap with the green pair, they score 18 points between this swap value plus this swap value is 18 points. Whereas if the green pair swaps with the red pair, they only score 7 points. So it seems like the green pair ought to swap with the blue pair. Let's go take a look at that. Here's our blue pair, our green pair, and our red pair. We know that the blue pair can give to the green pair, and the green pair can give back to the blue pair. We know that the green donor can give to the red donor, and the red donor can give to the green donor, and here's our choices. So it seems that we should give 1 to 3. But it turns out that 1 could also give to 2, and 1 could give to 7 in addition to the other things that's going on, and 7 could give back to 1. And that scores 11 points. So now we have these 3 different options, but if we do this one, we'll use the green pair with the blue pair, and these 2 pairs will be untransplanted. So do we do that, or do we do these help 4 people and score 19 points rather than the 18 points that we got if we just did 1 two-way exchange? So you can see how complicated this gets. And now imagine that we have hundreds of pairs. In this example, I'm showing you all the possibilities from just 41 pairs. So imagine if after today's conference, we sent you home with a homework assignment that your job was to look at this horribly complex matrix and try and figure out the single best solution that transplants the most people. The beautiful thing is that software can help us do this very quickly, and I'll show you how that works. So it turns out you can do this 3-way, this 3-way, you can do this chain of transplants, and you can do this 2-way exchange. And so the best solution, when a computer does it, shows that you can do 18 possible transplants out of 41 pairs. So that's why you need software to help you do this. Now imagine that you had hundreds of pairs in the system. Not only would it be nearly impossible for a human to figure it out, it would take an incredibly long time. And that's the beauty, really, of software. The software makes kidney exchange easy. So kidney exchange is hard for human minds to do, but it's easy for computers to do. The other beautiful thing about computers is that they can fairly apply the principles, such as the number of transplants versus the quality of transplants, and help us make choices that balance quality and quantity fairly across different transplant centers. Our plan, as we try to help India expand, is to try to do transplants at the local center first, and then for harder to match patients to try to do them at the regional level, maybe even across state boundaries, once we figure out how to deal with the complexities of the authorization committees in different SOTOs. So local first and then regional will be our plan as we expand. Here's just an example of what the software can do. This is the actual image from the software. I'm guessing that Vivek will be telling us about it, but I'm bragging a little bit about him to tell you about the 10-way exchange that he was able to do using our software. So I want to close with a few important principles. Every transplant center can participate independently. You can put your pairs in, and you are in charge of your own data. The system is very secure, yet it allows you to share your data with others in a very controlled fashion, where you show them the things that from your center that they need to see, but they can't see everything in your center. And while this allows that while each center is in control of their own patients, it makes it easy for different centers to work together. As I mentioned early, we've been given a large grant from Stanford Impact Labs, which funds big ideas to try to help them expand and grow to scale. And that's exactly what we'd like to help you do in India. So we were chosen to try to help grow kidney exchange in low and middle income countries. And the two countries we're trying to help are Brazil and India. So, as I mentioned, we can now offer access to all the services that we provide at no charge for the next 2 years. And I'm pleased that we've been able to bring on new staff that I'll introduce you to at the end of my talk. We're supporting, for example, a coordinator in Calicut. So, in summary, kidney exchange is easy with software support. It's less expensive than doing desensitization. Swaps are not only allowed with near relatives, but now NOTO is encouraging them. And we believe that kidney exchange can increase transplantation by 20 to 30%. So I'd like to thank again the NATCO and the Mohan Foundation for making this possible. And while watching me, you might think it seems impossible to do it at your center. It's only impossible until it's done. And here are the people at the out to. Thank you very much.
Thank you so much, Mike. I can already see questions coming, and I would like to tell everybody that we do have time to ask questions and have some discussion at the end of when all the speakers have finished talking. So at this point, I would like to invite our next speaker, Dr. Vivek Kute. Most of you know him. He's a leading figure in nephrology and kidney transplantation, especially known for his pioneering work in swap kidney transplants. He serves as a professor of nephrology and transplantation at the Institute of Kidney Diseases and Research Center and Dr. H.L. Trivedi Institute of Transplantation Science in Hyderabad, IKDRC as it's called. With unmatched expertise, Professor Kute has overseen over 600 swap kidney transplants. I hope I have got the right numbers, including India's remarkable 10-way swap transplant that Mike just mentioned, a milestone that has demonstrated how kidney swap donations can increase living donor transplants by up to 30% nationally. He's also led the largest multi-center analysis of kidney exchange transplantation in India, encompassing 1839 kidney exchanges across 65 centers from 2000 to 2024, with swap chains ranging from 2-way to 10-way transplants. Professor Kute holds several key and international roles. He's a secretary of ISOT. He's the counselor at the Transplantation Society, counselor Asian Society of Transplantation, member WHO Task Force on Transplantation, member DICG. And he's going to now today be speaking to us on how to build an exchange program in government or charity hospital setups, a practitioner's perspective, and advancing a national framework, one nation, one swap. Over to you, Dr. Kute.
You're muted.
No, he's not muted. The host has muted everybody. So, Yogita, if you could just look into it.
Done, ma'am.
Okay, thank you.
The PPT is visible?
No, not yet. You've not shared it, I think.
Actually, I'm joining from new desktop.
Okay. Just remove. Yogita, do you want to remove Spotlight? With that help?
No, ma'am. He had shared it before.
Can I send you PPT at your end, Pallavi?
No, you were sharing. You were sharing.
Yeah. He was sharing before.
You just need to change the so you're sharing the
tab maybe.
Okay, you're sharing now. Now you just need to switch to the presentation on your screen.
Masterclass, the next one. No, that's
No,
that
no,
is
that's
the
for
public.
Zoom.
Just change my laptop to Apple, so I'm not familiar with the Windows.
You're gonna love it once you get used to it.
Sorry about that.
Not an issue.
Pallavi, should I share with you
Yeah,
PPT?
you could do that. I can
Okay, I just send you on WhatsApp.
WhatsApp. Oh,
I can try to guide you if you want, Vivek. If you
Okay,
share your screen again
okay, sir.
and then go to the very bottom, there's a bar across the bottom that shows Google and Windows and Word, and
Okay, sir.
click on the PowerPoint after you share your screen.
Okay,
You haven't shared yet.
okay, sir.
Do you see the green button at the bottom?
Yeah, green.
So click the green share button.
Share button.
It's right in the middle at the bottom of if you're looking at the Zoom screen, it's right at the bottom in the middle.
Okay.
There you go. Now you're sharing. Now go to the very bottom of your screen and find the PowerPoint and click on that. Do you see at the very bottom the PowerPoint, or are you using a PDF maybe?
No, it is a PowerPoint.
Do you see down at the very bottom bar, are there a whole bunch of icons that you can click on? Like PowerPoint, Excel, Outlook, Word.
if you want, I could share it. I now have it on
Okay, please share.
1 second. Just downloaded it.
Ma'am, you want me to share?
No, I'm just. So you stopped your sharing. Can Dr. Kute please? Is it shared?
Yes.
1 second. Okay. Dr. Kute, you let me know when to change.
Right. So thank you, Natco, for giving me this opportunity to interact with you on the swab transplantation. So I will be discussing our experience at Kidney Institute Ahmedabad, our recent publication on multi-center swab transplant, and way forward for the One Nation, One Swab Transplant program. Next slide. India is number 3 in the world for absolute number of organ transplants. But this is mainly because of living donation. Next slide. Less than 10% of patients with end-stage kidney disease have access to organ transplantation. And one third of the living donors are rejected mainly because of HLA or ABO incompatibility. So swab transplant is a simple solution to increase access to the kidney transplantation. Next slide. This is example of two-way exchange where two pairs exchange kidney with each other to receive more compatible transplant. And one of the most important advantage of the swap is that it also reduces the deceased donor waiting list. Next slide. So why swap transplant is more useful for Indian scenario? 85% transplants in India are from living donation and around 15% are from deceased donation, which is active mainly in the South and West India. So we need solution to increase access to transplant with the living donation. Can you go back?
Sorry.
So this is the India map showing distribution of living donor kidney transplant. The green shade is showing that living donor transplant is more active, and red color is showing that living donor transplant is yet not initiated on the left panel. On the right panel, we can see distribution of the swab transplant in India. Gujarat is doing maximum swab transplant. More than 600 so far is recorded from our single center. After Gujarat, Maharashtra, Delhi, Rajasthan, Punjab, and Kerala, as shown in a dark green color. These are the states with more swab transplant. And again, the red color is showing that swab transplant is not initiated in these states. Next, next slide. So why there is a disparity in access to the swab transplant in different states? Like Gujarat is doing extremely well as compared to many other states. So basically, swab is bureaucratically complex and medically simple. And ABO incompatible transplant and desensitization protocol are medically complex and bureaucratically simple. Next slide. So I will be discussing this single center experience at Kidney Institute Ahmedabad, the largest public sector transplant hospital in India. So far, we have done more than 7,000 kidney transplant. 80% are living donor, 20% are deceased donor. So out of 539 swab transplants reported in this publication, 75% are two-way exchange. Two-way exchange are logistically simple. Then 16% are three-way exchange, and less than 10% are four-way and longer exchange. We usually prefer two or three-way swap to overcome surgical limitations to need larger surgical team for simultaneous transplant surgery. But we have reported longer chain when this increases access to difficult to match patients like highly sensitized patients and O group patients. Our median follow-up is 8.2 years. Graft survival is 91%. Patient survival is 82%. Rejection rate is 10%. Serum creatinine is 1.3 at median follow-up of 8.2. Patient survival is less as compared to the graft survival because infections are common because of tropical infections, and death with functioning graft is common in India as well as Asia. So this largest single center experience and we reported challenges and solution to replicate our success in other swab transplant programs in India. Next slide. So this is a year-wise progress at our single center. We started our first swab in year 2000. From 2000 to 2011, for the first 11 years, we did hardly 56 swab. In 2011, we started a organized registry and teamwork. Thereafter, there is a substantial growth and progress in a number of swab transplants. In year 2015, we have reported 75 swab transplants in a single center, and this has increased our donor pool by 25% in a single center. That is our publication. And in year 2025, in 5 months, we have done around 50 swab transplants. Next slide. So, how much swab transplant increase LDKT pool? This is a percentage over the last 25 years. So for the 2000 to 2010, swab has contributed hardly 1 or 2%. In year 2015, swab contributed to 25%. And in year 2025, which is not shown here, the swab is now contributing to 30% of living donor kidney transplant in our single center. Next slide. So what are the key features of our success? Awareness and counseling about available options of renal replacement therapy, swab, ABOI, desensitization, cadaver transplant. Then we have started a registry in 2011 with the help of Professor Rees and APKD team. Then dedicated teamwork to overcome logistic support for the swab, uniform evaluation of the patient and donor, standardization of HLA laboratory, early registration, complete workup of patient, transplant evaluation before final allocation, robust immunological evaluation to prevent unequal outcome because of immune injury, non-anonymous allocation increases trust between the patient, transplant team, and administrative team, then exchange kidney of similar quality, and we prefer simultaneous surgery, but we have reported around 100 non-simultaneous surgery when the chain length increases 4-way and more. Next slide. So in January 2025, we kickstarted the new year with 17 swab transplants in 2 weeks. This included the first 7-way swab transplant of India and 5 exchange of 2-way swab transplant. These surgeries were performed non-simultaneously. We usually perform 2 transplants per day, and we have the mechanism to prevent the donor lineage, and so far over 100 non-simultaneous surgery, the donor lineage is 0%. Next slide. Last month, we performed a chain of 10 patients and 10 donors. Again, transplant surgeries were performed over a period of 1 week to overcome surgical capacity for the simultaneous surgery. Next slide. So now it is time to start the city-based program, state program, and the ultimate goal is a one nation, one swab transplant program before we think of international kidney exchange. So swab should be available in each transplant unit. At least we should do counseling about the swab before cadaver registration. So almost many time patients have incompatible donor, and we can increase access to living donor transplant by at least 10% if we do counseling about the swab before deceased donor kidney transplant waiting list. Next slide. So this is our recent publication in Lancet Regional Health Southeast Asia, a nationwide retrospective cohort study, 2 decades of kidney and liver exchange transplants in India. This is data of 1839 kidney exchange from 65 centers and 259 liver exchange from 7 centers. So our center is doing software allocation with the help of software provided by APKD team, Professor Rees, and many other centers are doing a manual allocation. In the kidney exchange, 87% are two-way exchange. So basically, majority of the kidney exchange are two-way exchange because more team is needed to carry out simultaneous transplant surgery. And in liver exchange, 97% exchanges are two-way exchange. Then there is a gender disparity. Recipients are male and donors are female, which is not uncommon, and this is similar to any other living donor transplant. And reason for joining the kidney or liver exchange, most common reason is ABO incompatibility. For example, 87% for kidney exchange. Because majority of the centers are not using software. If we use a software, this will increase access to difficult to match patient. So this is largest cohort of kidney and liver exchange data published from 72 centers. And this shows that swab transplants are medically simple but logistically complex. And access to kidney and liver exchange was unequally distributed as shown in the India map previously. Next slide. So year-wise, the participation of swab transplant is increasing in India over the last 25 years, especially after including swab as a terminology in Transplant Human Organ Act in 2011. So over the last one decade, there is a substantial growth in number of swab transplant in India. Next slide. So now it is time to start the national program. I would like to thank Dr. Anil Kumar sir, Director NOTO, for his recent advisory to all the states about the document checklist required for the swab transplant. It is already mentioned in Transplant Human Organ Act, and this advisory from the NOTO is useful so that this decreases the waiting time to make the legal permission for the swab. So one of the advantage of the national program will that this will increase the donor pool by 25 to 35%. So when donor pool will increase, this will also increase quality of matching and quantity of matching. Especially this will increase access to difficult to match patients, O group patients and highly sensitized patient. Next slide. In the multi-center program, less surgical team will be needed to carry out simultaneous transplant surgery. That will be another big advantage of multi-center and national program. Next slide. So I will express our gratitude to Professor Rees and Professor Alvind Roth for guiding our center to expand our single center program and his guidance to other center as well. Next slide. So now the vision is a national program, One Nation, One Swab Transplant program, because this will increase access to living donor kidney transplant by 25 to 35%. And there should be counseling about the swab before deceased donor waiting list. This will increase the living donor transplant by at least 10%. Then living donor advocate and swab patient ambassador program we are using very useful. Then one nation one document checklist as per form 3 documented by Transplant Human Organ Act in the recent advisory by the NOTO that is now followed by majority of the stakeholders. So this is very positive step to reduce the waiting time for taking the legal permission. Then we propose that single digital registry all over the country, then single portal for allocation and single window for taking the legal permission. This will decrease the logistics in the swab transplant. And in a multi-center program, in national program, we can arrange interview of the patients and donor on the online platform. We can arrange a legal permission with the help of digital innovations. We can do personal identification of documents with the help of Aadhaar-enabled biometric clearance system. Then donor travel or kidney transport both is feasible for Indian scenario. As per the consent of the patient concurrent with the transplant team, both can be possible. Then currently for the Indian scenario, majority are using only near related donors in certain states with permission from the state government, especially in the Kerala. they are giving permission for other than near related donors as well, because of the high cost required for ABO incompatible transplant that can be implemented at the national level. So teamwork is needed to for success of one nation, one swab transplant program. Thank you for your attention.
Thank you so much, Dr. Okay, that is really amazing work by your center. Huge inspiration, I think, for the rest of the country. I'd like to now invite our next speaker, Ms. Bhavna Shah. Bhavna is the Medical Administration Manager, Medical Administration, Dr. L.H. Hiranandani Hospital, Powai. Bhavna has more than 22 years of experience in healthcare and in transplant. She's currently the chairperson of ZTCC Mumbai and is also representing ZTCC in the Roto Awareness Committee. She has been actively involved in the training program of ZTCC and Roto for transplant coordinators. She'll be speaking to us today about the role of transplant coordinators in swab donation. Over to you, Bhavna. Bhavna? Are you there, Bhavna? Do you need to unmute yourself?
Now you can hear me?
Yeah, we can hear you.
Yeah. Wait, I'll just share my. The PPT is visible?
Yes. You want to put it in the slide mode?
And go to slide 1.
Yeah. So thank you, Natco and Mohan Foundation giving me opportunity to talk on a swab transplantation. It's a really very meaningful conversation, the one nation, one swab transplant, because how the Dr. Putte, Dr. Michael has spoke about, the importance of the transplant. And there are a lot of couples who really have a problem with the ABO, like the non-matching of because of the HLA or blood group. So they have one more option to go for a transplant. So sir has already explained about what is a swab transplant, how we can do in between, whom we can, exchange. So I'm not going through that, and I directly come why swab transplant. So definitely the organ failure patients who don't have a, match donor, they can go for a swab transplant and hope for them. See, the waiting list is very big. If I talk about India, the donor waiting list is very big. For recipients, waiting list is very big, and they're waiting for a donor. And it's really difficult to, have a match. So swap is one of the best option for them, and we have to thought about that. So what is the advantages? What a transplant coordinator can explain in their counseling, when the patient is coming. So basically it's a reduce the waiting time. How, like I told you, the waiting period is too much in a waiting list. So we can, reduce the waiting time for improve the long-term kidney function. We have a better match. If we go for a ABO incompatibility, a lot of plasmapheresis and a lot of other things is involved, and maybe the graft success is percentage is less. So you will get a better life, long-term kidney function, better graft function you will have. Overcoming the compatibility issue. When it is a swab transplant, we can match a better way. We can see the blood group, HLA compatibility, other things, age and other things, and we can match better way. Expand donor pool. We can expand the donor pool, like allowing incompatible donors to still contribute to the transplant. We are doing here most of the time here, we are doing only a 2 pair. But if we, maintain a registry, we go more, we counsel the patient, we understand when we can, extend the donor pool, and we can go for a like 3 or 4 transplant. Reduce the dialysis duration for the kidney patients. Definitely it is a cost impact. So we can, and the lifestyle, their lifestyle, we can improve their lifestyle, if it is, they get a good match donor. increase the transplant numbers. Definitely how Dr. Kutte says they have increasing. They showed the graph, how they have improved the numbers, and a lot of people are now interested. They are coming to the, for the, they are coming forward for the swab transplant. So we can increase the number. We can decrease the waiting list, like the patient who are waiting on for the cadaver disease donation. Potential for a better graft survival, which I have talked. Cost is one of the important point on a patient point of view. When they go for the ABO incompatibility, definitely the cost increase for the plasmapheresis, for the hospitalization, maybe sometime the graft success and all that. So the lot of cost involved in that, and this is the pinch. The patient is already on a dialysis. They are spending so much money on that. So this is the, if they get a better match donor, there's definitely the immunosuppression, other things will be the less, and they get a good life. Improve the quality of life. Definitely the better match is always have a good life with the success graft. They can significantly improve their quality of life and allow them to free for a dialysis and live more normal life. So how we go for a swab transplant? So basically here in Mumbai, we have all hospital have their individual registry, as we have some normal registry also, but here basically Mumbai hospitals, they maintain the registry. When the donor come for the disease donation, they come for the just registration of the disease donation. That time we take the details. We ask them, always in our counseling, we ask them if they have any donor in the family who want to donate. So we just check that. According to the our law, THOA, it is, if it is a near related donor, we try to explain them what they can do, what the more they have the options for the go for the transplant. So we enter the donor recipient's name, age, blood group, contact details, their nephrologist name, most of the details we try to capture from them, so we can share with the nephrologist, so we can try to a better match. If we found any pair which they have a good compatibility match, we talk to the consultant also, or maybe sometime consultant also, they inform us if this is the pair, we have a better match and we can go for a transplant. And definitely we do the medical fitness of the donor and recipient. If it is a better match, we can go for a swab transplant. So what is the legal documentation for the swab transplant? So swab transplant is legally allowed as per the THOA. They have in a section 3A, they have a written that in a near relatives, we can go for a swab transplant. I think so Dr. Kutte has written in that what we have needed, other than a near relative, we have to allow. Definitely. So right now we have a restriction. We can go for a swab transplant only in the between the near relatives. So in the near relative definition, it comes spouse, son, daughter, father, mother, brother, sister, grandfather, grandmother, grandson, and granddaughter. So they are as per the definition of near relative. There are some paperwork we required to do that. Like we use as a near relative, we use form number 1 for that. If it is a spouse, as on paper they are related, so we count as a near relative, and form 2 we use for that. There's a form 4 certificate as per the THOA Act. Form 5 we do the genetic compatibility in between, they are in near related or not, we just check that. Form 11 for the joint application, we require some more documents which we ask, some affidavits, some identification proofs and all that as per the our legal requirement. And it's very some state, but I really I think so in last NATCO we have talked about that we want one nation and one document checklist. So many states, sometimes they are using, health is a state subject. So maybe they tell us to, give us some different documents for the approval and that. But we want to, request NATCO, okay, there is a one checklist for one nation. So it will be really effective for the patient, and it is a swab transplant later. It is a benefit for the swab transplant because people will aware that what they have to do and what they have required for the transplant. So this is a basically overview about the from transplant coordinator side. What can they do? Counseling. They can better a counselor, so they can counsel them about the benefit, so they can come forward and participate in a swab transplant.
Thank you so much, Bhavna. That was really good. And we are going to now open the last 10-15 minutes for discussion. And at this stage, I would like to also welcome Dr. Dinesh Khullar. Uh, Thank you so much, sir, for being with us today. Dr. Khullar is the chairman and head Department of Nephrology and Renal Transplant Medicine at the Max Super Speciality Hospital, Saket, New Delhi. Dr. Khullar has been involved in over 5,000 successful kidney transplants, including a large number of ABO incompatible, highly sensitized recipients, and other challenging transplants. Dr. Khullar has been the Executive Council member of ISOT from 2023 to 24. He was a former president, Delhi Nephrology Society. And I'm at this stage also going to invite my colleague, Jaya Jairam, to moderate the discussion and invite the speakers to share their views. Over to you, Jaya.
Thank you. Thank you so much, Pallavi. Well, the world of transplant has always deeply inspired me, especially because I'm a kidney recipient myself. And so at the Mohan Foundation, we lead a patient support group where we see the real impact of organ donation transplantation every day. So it gives me great pleasure to moderate this session, which brings together some leading experts to share their insights. My first question is to Dr. Khullar. So, with your rich experience in kidney transplants and swaps, and as the chairman of Max Hospitals in Delhi NCR, could you share with us some insights with respect to implementation of the kidney exchange across the Max Hospital centers across Delhi NCR?
Well, thank you very much, Jaya, for that very important question. And at the outset, my sincere thanks to Mohan Foundation and Co for this wonderful opportunity. I think I truly believe this is the need of the hour. And certainly a big thanks to all the three speakers, a wonderful job done. I have had the pleasure of interacting with Michael Rees a number of times, a brilliant surgeon, but now I think more famous for a human service he's doing internationally by promoting this very, very effective software. And why I say so is because we have the fortune of having access to this software for about a year's time now, and it's slowly and gradually we have understood the nitty-gritties. And now I truly believe that we are going to be doing a better job than what we have been doing all these years, even though I personally have been associated with a lot of paired kidney donations, but then we always have to look up to these kind of technological advances via this wonderful software. And we have ample proof when Vivek, who has been using this software, has actually been leading the path as far as the paired kidney donation in this country, at least, is concerned. So, wonderful talks. Once again, a big thank you. And I'll come to the question which you have asked. You see, there are admittedly a lot of problems, and if I look back, and I also personally must have been associated with paired kidneys, as Vivek was saying, at their center it got started in 2000. Way back in 2000, I think I also may have been a part of such an endeavor way back then itself. But then for us in India, all these years, a paired kidney meant bringing two different families together. And that's easy. And that's what we do not really have to scratch our heads because, as Mike was saying, it's only the software which makes things easy for us. But I think when it comes to the two-way swaps, there's not really much you have to apply in terms of your brain. It's there in front of you, whether it's and typically we were talking about ABO incompatible transplants, and certainly the easy ones, A to B and B to A, or vice versa. So it was easy all these years, but we knew that there was certainly more which was required in our country as well. And this was at around the time when disease donation was not really picking up. Hats off to Mohan Foundation and so many other organizations which have done a great service to the nation by popularizing the disease donor transplants. But we must admit the south part of the country may have been better as compared to others, but then again, I would feel till about a decade ago, even the numbers from a distance, as far as even the south of India was concerned, was not really flattering when we compared it with other countries. The numbers are growing, and we are very happy to see a big progress in the disease donation in our country. But we all knew that it's not enough, and we certainly need to look beyond deceased donors to expand the pool. And this was at the time when we certainly gave a lot of importance to both ABO incompatible transplantation, which I think had seen a resurgence way back in 2012. Dr. Gandhi was doing, a few other centers were doing, but there were sporadic cases of ABO incompatible. But it really took off with the availability of those adsorption filters way back in 2012. And I think at around this time, we also starting to look at the paired kidneys in a different manner. So we were once in a while getting a kick out of it by saying, okay, we also do paired kidney exchanges. We bring two families together. And if you were ever able to bring two families of different religious thoughts or of different origins, so you probably certainly got a kick out of it. But I think this was more from the point of view of getting recognized that, yes, you also are doing such a service. But certainly it was not making any difference to the actual numbers. So why was it not taking place is what I think, Jaya, your question expects me to answer. And I think I'll put my thoughts now in that direction. So one of the things is what we have to learn from Mike, that human mind cannot interpret the kind of nitty-gritties. So it's when it becomes more than two-way, when it becomes the complex paired kidneys. So you have to have a good, dedicated, well-developed software. We were lacking that. It's only now I can say that because we have had the opportunity of having that software with us, and now I can understand. Certainly coming from a person who is a Nobel laureate, so it certainly has its weight behind it. So that's one. And secondly, we had to move not just the typical ABO incompatibility, we also need to look at the HLA incompatibility. That also is a big thing. And obviously, human mind cannot decipher typically that what is written in that single antigen bead assay, what the report throws at you. So I think we needed a software, and now we had it. But this gives us an answer as to why we were feeling deprived of such a thing. Well, that's one. Secondly, moving forward, I think there is definitely an inherent inertia in everyone's mind when we take up a new job, and especially if your hands are full. And I can speak for many of the prominent nephrologists across the country, with just a very handful of nephrologists taking care of a large number of patients with kidney diseases in our country. So they are already overburdened. So when you tell them to do something out of box, it certainly needs some extra effort. So whether I may be interested in promoting this concept, but do I really have the time to spare for this kind of a great initiative? Probably the answer is no, which would mean that I would be wanting to be a part of it. I may actually attend a few meetings, but when it comes to implementation, I may be found wanting. So which means that you really have to have not just the passion, but also the time and the inclination to be able to deliver. So that's something which is an important point. Few other points. The skepticism, will it really work? So it's only once you get the examples. I mean, it's a game changer when Atul told me, in fact, that they have done it even when it involved people from the so-called staunch enemy countries. So they did that some part in Middle East. So that speaks volumes. So it's not just transcending the religious barriers. It's looking beyond your personal enmities and doing something for the cause of the suffering humanity. So that's two. So if someone tells you that someone elsewhere in the world has done it, you will feel inspired. Coming back to your own country, if someone tells you that it has been possible to do it interstate within your own country, it gives you some kind of confidence that, well, I can also do it. Short of that, there was a lot of skepticism. Why I say so? So it'll be like typical thought. Well, what happens if the two authorization committees are belonging to two different states? That's one. Two different organizations, one from the government public sector, one from the private sector. One is a typical, I would say, very, very busy unit, would probably the busy surgeons, the nephrologists do not have the time and inclination to really devote such kind of extra time to the cause of this endeavor. Is again, but this is with great optimism when I hear Vivek talk about One Nation, One Swap program. So which means many of the hurdles which are inherently there are going to be raised when it comes to. So when the
I'm getting an echo, so I'm
Sorry.
wondering if everybody else.
I'll just change my position a bit. Is it better? Is it still happening?
No, the echo is still there, Dr.
Can
Kula.
the organizer mute across everybody
Yep.
and then see if that works?
Yes, maybe. So tell me if I'm still the voice is echoing or not. I'll keep on changing my position. That's all we can do. I don't think I have any other electronic device interfering with it. So I wonder why it's happening. Normally it doesn't. Still doing, Pallavi?
Yeah, we're still getting the echo, Dr. Kula. And it suddenly started.
Yeah, you are
I
fine.
don't know. Let me put my mobile on flight mode. Then probably is it happening now? Still?
Yeah.
I'm sorry. I'm sorry. Maybe I'll keep on trying. I'll keep on moving a bit. And okay. So I'll. So phone is away. Phone is actually on the flight mode now. But I don't know why I'm still getting it. I'm sorry for this technical glitch. Normally never happens. Probably first time happening.
Time I've heard, and you were fine all this while, and suddenly it started a couple of seconds ago. So maybe just move.
Yeah. So is it better now?
No, Dr. Kula.
Let me go to another room. So give bear with me. Yeah.
Dr. Khuller, let me come back to you. If you could just try exiting and rejoining. I have a few more questions for you. So if
Okay,
you could
sure. Is
Yes.
it now better? I'm in a different room.
No, the echo is
I'll
very
rejoin. I'll rejoin. Okay.
Yeah. So we'll come back to Dr. Khuller, but in the meanwhile, I had the next question for Dr. Kutte. You've been performing swab transplant since 2000. That's some amazing work that your institute has done, your team. And subsequently, you did mention that you've gone in for the APKD package, the software for swab matches. Can you tell us about your experience when the swabs were done without the software as compared to after adopting the APKD system? Dr. Kutte?
Obviously, the software matching is always better. One of the fear is that if we do a manual matching, the unequal outcome, there is a chance of unequal outcome in any swap, like 8 to 10% because of rejection. It could be blamed to the manual allocation matching. So this software is very user friendly. We can make a long chain. Basically, with the manual allocation, we can make a two-way chain. But if we want to make a, just like in January 2020, just before COVID, we have done the longest cycle of SCR, 10 patients and 10 donors were operated. This include 3-4 sensitized patients, few difficult to match patients that could not be possible with the manual allocation. So obviously the quality of matching, quantity of matching, access to difficult to match patients, they will be always better in the software allocation. And this is very user friendly.
Yeah, you're muted.
I'm sorry. Am I audible?
Yes, please.
Hello? Yeah.
Yes.
So I was just saying, Dr. Kute, that yes, we could see it half spoke for itself, the number of transplants, the jump and the exponential growth. So that's amazing. I'm going to come back to you, Dr. Kute. My next question is to Dr. Rees. Dr. Rees, you did briefly mention that ABO incompatible transplants is more expensive, needs more immunosuppression. Could you elaborate on how the outcomes of swap transplants compare with desensitization that is used in ABO incompatible or HLA incompatible transplants?
Sure. So when you do a paired exchange transplant, you're just doing a living donor, straightforward living donor kidney transplant. So you don't need to use additional immunosuppression. You don't need to use stronger induction agents. You don't have to use higher doses of the post-transplant medications. You don't have to do plasmapheresis and IVIG. Plasmapheresis and IVIG doubles the cost of a kidney transplant, and it increases the risk of post-transplant complications and infections. As we heard from Vivek in his presentation, in India, if you didn't get infections, which killed 20% of people, then you can get 91% graft survival, which would be amongst the best in the world. And that's because, you know, in the Indian population, there is less rejection than in other ethnicities. So there's an opportunity to have terrific success rates if you do straightforward transplantation. But if you add additional immunosuppression, you increase the risk of infection, and infection oftentimes leads to death. So it's very important to try to minimize the immunosuppression, and one way to achieve that is by not doing ABO incompatible transplantation.
Sure. Thank you so much, Dr. Rees, because we do come across cases where patients who cannot afford regular transplants, straightforward transplants, they are advised to undergo an ABO incompatible. So it just leads us as to they are poor, they can't afford it, and B, they've been advised to go for ABO incompatible. In our minds, a swap would be a relatively straightforward option. So, thank you. Is Dr. Kullar back? Dr. Kullar? No. All right. So my next question is to Bhavna. You've coordinated many kidney transplants in your career, and you do work closely with patients and donors. How do you counsel patients to opt for swap transplants, sorry? And generally, what are the typical concerns that they usually raise when it comes to swap transplants? And also, what are the challenges that you face when you are sitting in front of the approval committee? So when you're presenting the cases to the approval committee. So could you just give us an insight on that, especially from the transplant coordinator's perspective?
Yeah. So basically, who have a match donor, definitely they easily go for the all living process, what required as a legally. But when it comes to the patient, sometimes they come for the registration and we ask them, you don't have any donor in the family. Basically, we start from there. When they wanted to do the registration, we ask this question. Basically, whenever I'm doing the counseling, I always ask this question: you do not have any family member to donate? So then they open, slowly they tell us, ki, this is the problem. This is not the, whatever it is, the incompatibility they share, must be they are sharing with the doctors, but doctors sometimes they cannot explain everything to the, us. So we ask them basically, and we try to explain I always try to tell them that you register yourself. You do the registration for the cadaver. This is definitely your rights to do that. But you register for the swab transplant also. And then I counsel them what is the swab transplant. If they want more information clinically, they can go to again a consultant and they can ask. But the common things we explain, how it is a cost effective, what is the benefits of that, the hospitalization. They understand the very lay language, so we explain in their understanding, according to their understanding. So we explain that if you sometimes they ask us about the avio incompatibility. Now in Mumbai they do a lot of avio incompatibility because they come for that and they ask for. So we try to explain there that avio incompatibility, your hospitalization, your plasmapheresis, your immunosuppression, your graft survival the exceeds that and all that. That's what we try to explain and counsel them. And whatever, if it is a clinically requirement, if any, then we tell them to come. We'll come with you, to the consultant. We'll talk to the consultant and we sit with them. There is some challenges also when we go for a swab transplant. In earlier phase, right now, though there are a lot of, the NOTO has given a clarification and all that, so it's easy. But in earlier phase, it was when there are two families are involved, so we have to understand sometimes both families are not come together. We have to, for the initial assessment and all that. Then surgery should be on the one time only, it's to be happen. So that was the challenges were there, earlier. I heard that Dr. Rees and they were saying they do the transplant, later on also in the swab. But here little bit, there is a list that if one pair transplant will done and second pair will deny, then what will be happens? So that threatening is still there in the here, that still it is there. They don't tell to the consultant, but when they come to us, they open up themselves, and tell the all whatever they feel, what are the problems and all that. Even documentation, if I talk about, so earlier I also told that the health is a state subject. So all state, they tell us what is the requirement for the approval. Like here in Maharashtra, if I talk about the Maharashtra, whenever it is a swab transplant, we took swab is in as per the THOA, it is in the near relative only. So we consider as a near relative. But when it comes to the swab, ultimately it's go to the other than a near relative. Like we are giving a kidney to the other family members, so it goes to that. And then the all stars, they feel that isme to ye form bhi fill hona chahiye, that also should be done. So paperwork increase and the family's anxiety and other thing increase, the requirement increase. So that is there in the still in the family, so it's required NOTO to stabilize the
Streamline the
process of
procedure.
streamline the process of the forms and format. For swab transplant, this will be required, so it's required like that way. And it's for the all state, not for the Maharashtra, not for the Gujarat, not for the that, but it is a one nation, one form checklist like that way. So it will be easy for the patient. They have a trust, they know what they have to do. They have a little this thing, about to go for that, and they come forward for this thing. So this is their for committee approval. Definitely here we are taking the approval from the hospital. Still we have to send as a swab transplant, we have to send to the government committee. So again, it is a 2 steps to go for that, so this is also a little one of the small hurdle to the patient to more waiting time. So we have to do something on that, keep they can get a clear. If we say as a near relative, let them take a clearance from the hospital committee and go for that. So this we have to do something on that.
Rightly said, Bhavna. Thank you. Dr. Kuller is back. Welcome back, Dr. Kuller. So my next question to you is, if the outcomes of swab transplants are clearly better than ABO or HLA incompatible transplants, why do you think many hospitals still hesitate to go and adopt the swab transplantation program more widely at a larger scale?
So thank you very much for allowing me to rejoin. I'm opening my mouth with a lot of fear and reluctance. So Pallavi, am I okay this time?
Perfect, crystal clear.
So I have my hospital's entire IT team sitting here with me now. So I just hope so we have tried to make amends. So let me finish, but I really wanted to the last time I was wanting to say something. You see, there were a lot of apprehensions, but I think I see hope when Vivek tells us that is going to be one nation, one program, because quite a few of bottlenecks are going to get removed, which certainly came in the way. One, of course, is going to be a set protocol. There is not going to be any ambiguity. So many times the authorization committees themselves were not clear, and they were actually creating a lot of troubles. So now, if you have that kind of clear instructions from the lawmakers, so obviously many of these ambiguities are likely to get removed. So that's one. Secondly, I mean, you see, working in a private hospital, let me tell you, there are some inherent fears. So no matter how much we try to refrain from using the bringing about the topic of the finances into it, till the time you address these issues, I think we'll be fooling each other. I'm not saying everyone is looking at it, but in the long run, so you may do a lot of things out of enthusiasm initially, but ultimately there is always going to be that inherent fear lurking in every physician surgeon's mind, what will have to happen to the patient. So I will tell you what we have done to address this, because we at Max Healthcare went in for this software, and Atul Agnihotri, Mike Rees, Sridhar here, and now with the able assistance of Trilly. So they are doing a great job, and they have been very, very supportive. So now I tried to involve everyone across my own organization in my capacity as chairman of nephrology. But you see, there were certainly a lot of difficulties initially. One, certainly, as I said earlier, the lack of interest. So the inertia was there. So it was like, okay, it's a great thing, but then I'm not going to waste my time. And then certainly all that you were expecting people to do was to give us more and no more number of pairs, because you see, this software will deliver only if it has more data. So till the time you feed data into it, there is not going to be anything meaningful coming out of it. So now finally, with the addition of more and more pairs, we are finding the results coming out of this very impressive software, which I alluded to earlier as well. So to answering your present question as to why the majority of the hospitals do not go in for swap or paired kidney donations, the answer is, again, majority of the times the transplantations are taking place in the private sector. And the only thing which really differentiates private from government is the speed with which work gets delivered in a private sector. Now, the patient comes to a private hospital with the total intention that his or her work will get sorted out within no time. And then, if you, on top of that, tell them to patiently wait, as we do in the case of deceased donor, so they have a donor within the family. They are not going to wait for very long. So I think it's the time, the quickness with which the kind of expectations which they come to us, it plays a big role. And on top of that, when there has been a lot of thrust as far as the ABO incompatible pre-transplant is concerned, the impressive results there as well. I'm not taking any sheen away from the role played by ABO compatible. I myself have been part of a huge number of ABO compatible transplants over the last 10, 12, 13 years. But that I know that what I believe, I strongly believe in 2025 is that given a choice, I would rather going for a paired kidney donation than an ABO incompatible. I must have had a great success stories to narrate when it comes to ABO incompatible transplant, going by the number of high titers and all those challenging cases which we did. But I must confess, there have been disasters as well. And I believe those disasters, the typical TMAs, which happen at times sporadically, though, thankfully, but once in a while, your confidence gets shattered, and you're not able to have your dinner that same particular night, and you regret having gone in for ABO incompatibility when you had a choice of a paired kidney, which makes things easy. Now, again, I would want to reiterate, it is not just about the blood group incompatibility. I always have been vocal about the fact that it also gives you an opportunity to find better matches. I mean, to be able to find that long lost sibling in that Kumbh Mela. So which means your own brother may not be as compatible to you HLA wise as compared to that long lost sibling or within that community great HLA matching. So I think we need to go in to factor in that important thing as well. So I must say that many of these shortcomings were happening simultaneously. One, the lack of good software. Number two, lot of I would say overhyping about ABO compatibility, ABO compatible transplants, and certainly the quickness with which people want to go ahead with their job in a private hospital. And we have to accept the fact that the majority of the transplants in our country are taking place in the private sector. So which means time is a big factor. But certainly, if and these bottlenecks. So I am quite confident that everything is favoring, as of today, everything is favoring paired kidney donations. So it's just a matter of time. We will see more and more success stories, more and more of us getting into it. Yes, well, I would still believe that deceased donation should be priority number one. But if till the time that takes place in our country, so let all of us unite to make that a big story. But till that happens, we have to expand the pool in the present scenario. And I think, and let's not treat ABO incompatibility as a competitor to paired kidney. So I think we should give importance to all, but certainly I would want to keep paired kidney donation higher than ABO. Incompatible for various reasons. It's just not the cost. It is also the overall success rate. Even if you lose one patient to a TMA, which is directly related to ABO incompatibility, I think we need to rethink as to whether we were doing the wise thing by going ahead with that, or should we have waited for a suitable donor via paired kidney.
Thank you so much, Dr. Fuller. Such,
Dr. Jaya,
yeah,
Dr. Jaya, just I would like to add here, I must appreciate Dr. Dinesh, tenacity. He has a lot of patients who are lined up for the swab transplant now using the software. I must appreciate, you know, the way he has gone ahead, bringing the entire team together and taking help of Trilly. And, he has made it possible that, yes, in the next couple of weeks, he is going to have a couple of swab transplants. Hats off to you, Dr. Dinesh. Thank you.
thank you, Dr. Fuller.
Yeah.
You spoke such honest conversations with great candor. We appreciate it. Yeah. Do we have any questions, Pallavi? Any questions?
There are one or two questions, especially this question around swab transplants between international patient ABOI swab transplant. Is that permitted or not?
I'd be happy to speak a little bit to that. So we have done some international transplants between the United Arab Emirates and India. And I think this is a tremendous opportunity for India because of the quality of work that can be done and because it can be done less expensively in India. However, right now, the only transplants that can be done in India are between Indian nationals. So you can only do a kidney exchange between an Indian national. So the way we were able to do this with the United Arab Emirates is there are many Indian nationals who live and work in the United Arab Emirates. And in fact, the expatriates exceed the Emiratis in the country. But what's really wonderful about the United Arab Emirates is that they provide care their healthcare system pays for all the Emiratis, but also the expatriates. So they have a wonderful system to provide transplants to expatriates with kidney failure. And they use our software for kidney exchanges in the United Emirates. So if they're not able to find a match in the Arab Emirates for an Indian national pair, that we have permission to match them in India, and they will actually help pay for the transplants in India because it's less expensive than paying for the transplants in the United Arab Emirates. And so we've been able to facilitate a couple of those transplants and are looking forward to expanding that. But it's only for Indian nationals. Vivek could perhaps comment, if he's still with us, that he did one international transplant for a Portuguese pair, but he had to get special permission for it. Vivek?
Agree with you, sir. Right, sir. You mentioned all the points very perfect, sir.
All right. I think this conversation and discussion, it really requires more time, and maybe we could include this discussion in our upcoming annual conference as well. But for now, I think we must wind up. And thank you so much, our esteemed speakers, Dr. Mike, for waking up so early and being with us here today. Bhavna, Dr. Kullar, thank you so much. While you're on a holiday, you are.
Madam, we need Madam, we need Dr. Vivek's phone number, please.
Sorry, say that again. You wanted some clarity on
Dr. Vivek.
Yeah. Dr. Kute? Are you there?
Yes, please.
Dr.
Yeah.
Vivek.
Yes, I'm here.
Yeah. Okay, doctor, we need your mobile number. I'll be needing your help, doctor, because in Tamil Nadu and Chennai, we have not started swab transplant in government institution, and I want to take initiative on that.
Definitely.
And I'll be requiring your help.
Definitely. I will be happy to help, whatever assist I can do, definitely.
Doctor, can I know your name, please? Hello.
I think, Palvi, I would just like to make one comment here, if I'm allowed. You see, it all depends upon your own passion with which you are wanting to drive, the kind of passion which Vivek has. And I think if everyone is going to align and believe that this is a great step forward, I think it's all depends upon the kind of conversation you have with your patients. You see, you have a detailed discussion with them, and you may actually be able to discourage them from going ahead with avian compatible transplant. Maybe they will wait for the right kind of pair. And what we often do is give them a time frame that, okay, we don't want you to wait endlessly. Let's wait for about a month from now, which everyone would agree to. And I think during this 1 month, and as Sridhar was mentioning, we have now have understood the software better. The results are probably going to come very soon because it all depended upon the data points. And now that we have more number of pairs being fed in, my colleagues across the organization, PAN Max, have been a big support, and everyone is now wanting to pitch in. And I think ultimately it's Trilly and her team members also who are playing their part, giving us the necessary support, taking our headache away, and with these kind of tricky things. So it becomes much easier if we have that kind of necessary support. And I would strongly advocate, and certainly Vivek, hats off to you for bringing in our common concerns, especially if an ex relative, not the near relative, is going to be allowed for a transplantation to his or her relative. Why isn't that he or she cannot be a part of the swap program? So these were, I think, some ambiguities in the law, which I'm sure are certainly going to get taken care of very soon, and this will certainly expand the overall donor pool. Thank you very much for this wonderful opportunity, Palvi.
we will end this masterclass. I would like to thank the speakers again. Mike, thank you so much. Dr. Kute, Dr. Kuller, Bhavna, thank you for being here and sharing your knowledge and experience with us.
Thank you so much.
Thank you so
Thank
much.
you. It was a pleasure. And Dr. Thiagu, I shared my contact information, and along with Vivek, I'd be happy to help you.
Great.
Thank you, sir. Thank you, sir.
Thank you.
Dr. Pallavi, thank you so much for wonderful organizing this program. Thank you so much, as usual.
Thank you so much.
You are a great lady. Thank you. Thank you.
Thank you. Thank you all. See you all. Bye. Take care.
Really,
Bye.
thank you. Thank you. Thank you.
Bye.